Good morning. So most of these data were supported by NIH, most of the studies I'll be talking about today. So what are the problems? The problem is that we get encoding distortion induced by the metal, and there's some things we can change and some things we can't. Cobalt is only second to iron in terms of its magnetic properties. We really can't change the orientation relative to the field unless we have really, really short patience. But we can ask more of the gradients. So in order to decrease the artifact, we can actually increase the strength of the gradients. And when it comes down to cobalt, with cobalt, you have to use a new pulse sequence. So these are called 3D multispectral imaging techniques. This is a resurfacing arthroplasty, so-called MARS. You can barely see anything. I can't see the neck of the implant. And now with these newer pulse sequences, which are now available across different device companies, we can actually see the anterior column. So in this particular patient, you could see in the MARS technique, I might wonder about what's going on in the greater trochanteric bursa, but I can't see the anterior column. Now, when I clean that up with the sequence, I can see that, in fact, there's no osteolysis in the anterior column. And most importantly, at that inframedial recess, which was completely obscured, now I can pick up the fact that there is, in fact, an adverse local tissue reaction with a thick synovial lining. So my interest in this topic really started before the whole concept of metal on metal came to light, and it was really the cause of bone loss. So in a cadaveric model, which was the only way we could really validate the accuracy based on known quantities of osteolysis, with equivalent specificities, MR had much higher sensitivity compared to CT or X-rays with bilateral Judet views. So how is this clinically useful? We'll look at this patient, this 56-year-old woman, 7 years following bilateral resurfacing arthroplasty. And maybe you question some periprosthetic lucency, but gosh, so much easier to see this fluid intensity on the left resurfacing arthroplasty of pretty substantial proximal femoral osteolysis. Then we asked, when all these adverse tissue reactions came up, of all the things that I can think about that what will correlate and rise to the top as having correlation with histology and the prevalence of ALVAL histologic scores. And in fact, it was synovial thickness. So adverse tissue reactions characteristic is not just a fluid collection, thin wall, but rather a thick-walled fluid collection, as you can see in this particular patient, just that very thick synovial lining, not just the presence of fluid. Of course, now with tribocorrosion, this can occur in all bearing constructs. You can see in this patient had a 36 millimeter head with a modular implant. This is an adverse tissue reaction, thick synovial lining, decompressing into the iliopsoas bursa. This is the same patient, same retrieved implant. You can see the degree of corrosion at the trunnion. So we had one surgeon at HSS who very fortunately put in hundreds of a dual modular recalled stem and made for a very nice study group. So what's characteristic about this cohort is really no fluid at all, right? So it's not just fluid collection. This is an aggressive synovial response where you just see these large areas of high signal around it. Of interest in that last cohort, about 25% of the patients were revised based on MR alone. They were asymptomatic, but had adverse tissue reactions that were confirmed by histology. So these can be severe with often very little fluid around it. You can see this just very thick, aggressive synovium that extends into the abductors and causes adjacent tissue corrosion. We then asked if we could look at retrieved implants, what can we correlate to in terms of not just histology, but actually having Tim Wright in our biomechanics department look at red lux and optical scanning of the retrieved implants. So this is a modular, rejuvenate dual modular construct. And here you can see an adverse local tissue reaction, that thick synovial lining right around it. Synovium was graded as ALVAL. Histology, you can see corrosion products. This is all in the same patient with characteristic perivascular lymphocytes with only modest deviations in terms of the optical scanning techniques. In contrast, we can see in this particular patient, this is metallosis. You look at the low signal intensity debris, it's very characteristic. That black signal, if you will, is typical of metallosis. and that was confirmed at histology. This is showing that perivascular lymphocytes, and then again, modest deviation, but of more biologically significant particles. So what rose to the top in this particular study, and just focus on probably the last bullet, was that the preoperative MR correlated with the femoral head volumetric wear. So this is imaging correlating not just to histology, but to the changes that we're seeing in the retrieved implant. So this is for J. I had to put in an infection. So here we can see surrounding soft tissue edema. Characteristically, infection will give you a pericapsular edema, which often the adverse local tissue reactions do not, and a layered or laminar appearance of the synovium. These are qualitative differences, and this patient was confirmed as MRSE infection. So we did this in knees as well, and just correlated to histology, or positive cultures, and actually had fairly good predictive value as well as good reproducibility of looking for infection on MR preoperatively. Now, it's not a magic bullet. These are qualitative differences, but they can be quite helpful. So let's just go over for a review. This is a normal hip. This is what it looks like, flat on MR. Infection is, again, that laminar with surrounding soft tissue edema. A polymeric response is often well contained, characteristically associated with some osteolysis. Metallosis, low signal intensity deposits are very characteristic, and of course the adverse tissue reaction, that thick synovial response. Then we asked, what about high-functioning hips? So this is a prospective longitudinal study of patients that love their hips, and we looked at resurfacing arthroplasty versus metal on poly and ceramic on poly as a control. So these are asymptomatic high-functioning hips. And what we found, in fact, was that the risk of adverse tissue reactions in the resurfacing arthroplasty was at 8 times the risk of ceramic on poly. Really no statistically significant difference between the metal on poly or the ceramic on poly. The resurfacing arthroplasty patients had slightly higher scores, as it was be expected. Of interest, serum ion levels were not helpful. They were not helpful, and in fact had inconsistent prediction of an adverse local tissue reaction. So what was interesting, so the prevalence was higher in the resurfacing arthroplasty, but the majority of this cohort had no adverse tissue reactions. The presence of posterior soft tissue edema is normal. It is not an adverse tissue reaction. You've got to have that thick synovial lining. Serum ion levels were in fact inconsistent, and we presume that MR would be an effective means of surveillance. So now you're wondering, how can I do this at home? And this is where we're trying to think about using radiomics to automate the evaluation of the MR data. So we had this hypothesis that we could do this based on the techniques that we're using. Radiomics has been around a while. It's not true machine learning in the sense that the concept of images as data. This can be first order, which is without concern for spatial variation within the individual pixels, or it can actually be second order, where you take into account the spatial relationships. So we used this particular study was done using expert domain knowledge. We used our characteristic protocol, and then with myself and one other radiologist, classified these phenotyping into all these different tissue reactions. So these create these so-called patches. So in an aggressive synovial, host-mediated synovial response like infection or an adverse tissue reaction, it creates a lot more of the patches, whereas even though the prevalence of things like infection was much lower, it creates a large number of pixel patches, if you will. And this is really the bottom line as we go look at the AUC performance of this classification. This is, again, the concept of having an algorithm predict this type of host-mediated synovial response. If we just take out the subset of pathology only, this was interesting. It addresses a scenario where abnormalities are identified and then radiomics is utilized to classify or subclassify the phenotype. So these are preliminary data, but it's interesting to think that we could eventually start automating all these processes. What about instability? This is a posterior approach. We can see the short external rotators are off. The posterior capsule is deficient. At the same time, we also want to evaluate posterior capsule, but also the abductors, and you can see the subselective denervation in the gluteus minimus and the stripping of the tendon. Some time ago, I did a study with Paul Polici where we looked at longitudinally at patients following soft tissue repair. They all failed. Dual suture technique failed at 4 months, and then 4 years formed scar in continuity. So if you look at this just post-operatively, this is a coronal, and then this is the axial. For 3 months on the left failed. But if I just show you the image on the right, you think it was normal. In fact, it's not tendon, that's scar in continuity, imparting stability to the hip. And just showing you the atrophy of the muscle in the posterior capsule. This one's kind of fun, anterior pain. I love to show this to our trainees. Pain inflection, you can see the edema pattern, and this is a proud cup digging right into the psoas seen here. And then this is a cup impingement on the psoas. This is a thigh pain study, patient with thigh pain, and you can see that there is a fibrous interface around the stem with a stress reaction on the inversion recovery, and then that interface around, this is a loose stem. And this is a loose, you'd see some radiolucency here in zones 1 and 2, but so much easier to see on the MR, the extent of that fibrous interface, particularly at the anterior medial margin. Sometimes in the setting of lucency, we will generate a bone marrow edema pattern, but it doesn't have a lot of predictive value, so don't wait for that. If you see it, it's great, but if you don't, it could still be loose. This is a loose acetabular component. Again, easy to see in cross-section. The edema pattern, and then all that fibrous interface. For contrast, I'm just going to show you here, this is a well-seated implant. You can see trabecular bone signal coming right up to the low signal intensity metal. So we look at this in a more rigorous fashion, looking at 212 hips and 206 patients, and with good reproducibility between 2 radiologists, the acetabular and the femur data here. The problem we have is cemented stems. Okay, that's the problem. In a non-cemented stem, easy for me to tell loosening. Cement, it's very hard to see the difference between the low signal intensity, the bonding, if you will, between the cement and the low signal intensity of the metal. This is just a fun case. Look side to side. If you look at the upper 2, just compare side to side. You could say this is a ultimate dual mobility. It's displaced all the way into the inframedial recess. You can see the liner is all displaced. X-rays are, of course, negative in this setting. Patient with left hip pain. And this is a cobalt. I put this in for Steve Murphy. This is a cobalt ceramic on ceramic hip. You can see that low signal intensity ceramic debris in the inframedial recess. You have to get used to looking at MR. Here is the CT. I think it's probably a little bit kinder until you get that learning curve of looking at MR. We can now do this in isotropic fashion. So again, Mars, which is not acceptable by my standards. Here I can pick up a fibrous interface with 1 millimeter slices now. They're truly isotropic resolution. And I can see a fibrous interface around the stem. I can sort of pick up the trunnion on the traditional Maverick. Now with these thinner slices, I can pick up the fact that there's low signal intensity debris. So I know that this is now a reaction that's going on. This happens to be polymeric. So we'd submit that MR can be used as a screening tool, at least based on our data, most accurate to assess adverse host-mediated synovial response and bone loss. They occur in all bearing constructs. Maximum synovial thickness is what you want to correlate to. And radiographic measurements, clinical symptoms, and serum ion levels alone do not predict the presence and extent of wear-induced synovitis. Thank you for your attention, and I recognize the NIH for support of these data.